So I'd like to introduce Dr. Peter Nora, who is known well here. Peter Nora is and his partner writer, sort of understated, quiet people, but they have a huge process. They're one of the largest DBS places in the country, and we're excited about having him come talk to us. He's actually even a pretty nice guy for a neurosurgeon, so we welcome him.
Thanks, Dave, very much, and really appreciate the invite here. I'm going to try to swing some spine into this too, but we're going to talk primarily about movement disorders and the use of DBS, and I'm keeping in mind that I have sort of a heterogeneous audience here. For some, this will be old hat, maybe a little boring. For some, it'll be very, very new. So the reason we do deep brain stimulation therapy is that it's neuromodulative therapy, and I'll talk about that in my next slide. We have a huge reservoir of patients who are suffering with these diseases. Primarily, we'll focus this around Parkinson's disease, which you all are pretty familiar with. And really, as with most surgical patients, as long as we're thoughtful about patient selection, we really can get outstanding patient outcomes, and we're going to talk about that in a minute. So what is neuromodulation? There are multiple definitions. Think of it this way. It's non-destructive alteration of neurologic activity. We can do it in the brain, in the spinal cord. It tends to be a wearable or implantable device, and it tends to be reversible and, again, non-destructive. Okay? I've just put some examples below of different things we consider neuromodulation, some which have been around a long time, some which are pretty new. But again, the idea is non-destructive, affects the nervous system, and it's usually wearable. Sorry about that. Quick historical vignettes. We don't want to spend much time on this, but I want you to understand how new, relatively speaking, treating movement disorders is. In Sweden, the first pallidotomy, which was a destructive lesion, was performed in 1952. And really, there was a period of time in the 60s, 70s, 80s, and 90s where we were really trying to create animal models to understand what movement disorders were, how the basal ganglia, how the thalamus all interacted to sort of create these very abnormal movements. It wasn't until 1987, really, which is recent time, where a couple doctors in France showed that if you actually put an electrode in the brain, you can help, really in a chronic way, stop some of the problems with movement disorders. And at that point, it was really only tremor, not the other cardinal features of Parkinson's, which we'll talk about. In 2001, there was finally an article in New England Journal, 18-center, multi-center trial, which showed, okay, this chronic stimulation of the brain compared to the best medicine, the best pharmacologic therapy, was superior. And now, today, we have over 100,000 patients treated worldwide. So very quickly talking about this study, for those of you who care again, these were the defining concepts within the article. And really, this really changed the game in terms of this idea, which again is a bit of a cultural anathema, of using electricity in the brain with a pulse generator or really a pacemaker. We could inflect a significant change in people's life and quality of life. This led to FDA approval in the United States. And this, again, what you see, those abbreviations below are targets within the brain, which I'm not going to get into too much. The VIM is the thalamus. The STN and the GPI are part of the basal ganglia. And again, the GPI below also. These are the three big diseases we talk about in terms of movement disorders that are treated with deep brain stimulation: essential tremor, Parkinson's disease, and dystonia. And these are also in order of their incidence, believe it or not. Essential tremor, which is the Katharine Hepburn disease, if people in the audience are old enough to remember her and her tremor in her voice, is 10 times more common than Parkinson's disease, which is 10 times more common than dystonia. Again, we're going to focus primarily on Parkinson's disease today. We'll talk a little bit about dystonia. Sorry about that. Very quickly, what we do, and we're going to start up at the top at 12 o'clock and work our way around the clock. Both Ryder and I mount a frame on the head. We do some radiology, which is MRI and CT scanning. We plan our target in the brain. We go to the operating room. We do other things to really refine that target. And with the patient awake the vast majority of the time, we insert an electrode in the brain. We test the efficacy of that electrode with the patient awake the vast majority of the time. It advises our placement, helps us make sure we're actually seeing relief of symptoms and that we're not having unwanted side effects. So, patient awake in the operating room, turn this on, we actually see if we're getting good resolution or control of symptoms. Okay? A picture of a patient, you can't really tell that his eyes are open, but again, no ET tube, very light sedation. There's a hole in the skull with an electrode in the brain, which is actually quite painless. Easy for me to say, I know. Okay? Why this is different and why we have to put patient in a frame, we're really using millimetric targeting. That can be the difference between an okay result and a good result. Really, over the last 10 years, this is what we've been aiming for, right? Where do we put this in the most precise place to get the best effect? To give you a sense of what we're talking about, we're trying to stick a piece of angel hair pasta in the back half of a Jelly Belly, okay? We're trying to do it in a safe way and reproducibly get it there the same time every time we do it, okay? This is just an axial MRI scan. The X's or the crosshairs actually are showing you an area called the subthalamic nucleus where we're trying to place our electrode tip. So millimeters do make a big difference here. This is just another example of an MRI scan showing implanted electrodes in a coronal view in the globus pallidus internus. So it looks a little big there because you're getting some basically inflation from the MRI scan, but it just shows you what these electrodes look like and how deep they are in the center of the brain. Okay? This is just a schematic showing you the electrode in the brain. The pulse generator or pacemaker looks very much like any cardiac pacemaker, except the wire runs underneath the scalp, underneath the skin, up to the top of the head. Can you be active with this sort of device? Yes. There's a person who's run an Ironman triathlon with Parkinson's disease with 2 electrodes in his brain. What's the rationale for doing this? When a person gets diagnosed with Parkinson's disease, one of the ways we know is that Parkinson's disease, we give them medication, particularly a medication called L-DOPA. L-DOPA improves their symptoms of stiffness, of tremor, of slowness of movement. That helps make the diagnosis. We know that they've got Parkinson's symptoms because that medicine works. There's no blood test. There's no real genetic test that we use. But really what's amazing about the medication is it really helps people initially. Really helps their quality of life be maintained. As time goes on, motor symptoms get worse. And the medicine itself can inflect new motor symptoms, which I'm going to show you, one called dyskinesia, which is kind of the opposite of Parkinson's disease. It's too much movement. Okay? I'm not going to get a test on this diagram, but all the medical students know this infamous diagram that we had to learn for neuroscience about the way the basal ganglia, the thalamus, and the motor cortex work together. Okay? We're not going to talk about it in this terms because I don't think it would interest most people. The key with Parkinson's disease is we make a neurotransmitter called dopamine. In our adult life, we lose our ability to make dopamine. We make less and less of it. In a Parkinson's patient, they basically more rapidly lose their ability to make dopamine. The result of decreased dopamine is that your body starts to slow, stiffen up. It doesn't move as fast. If anyone's played basketball, soccer, hockey, think of the breakaway pass, the open goal or net in front of you. You're moving as fast as you can. Your brain says, I'm going as fast as I can, full speed, the anxiety of the defenders chasing you. And then as you get to the goal, everything slows down. And it's the beautiful layup. It's the chip shot over the goalie. We take that for granted. That's what this is all about. Your brain has the ability of very active circuits making you go 1,000 miles an hour, and those circuits in an instant slowing you down into something smooth and controlled. Really phenomenal. That happens in an instant. More powerful than any supercomputer that exists right now. So why do we do this? Let's just look at this. And again, I don't want to spend too much time with video, but to give you a sense of why we do this. Before and after. Okay? 45-year-old advertising executive. Okay? 45-year-old. And this is basically equivalent, meaning he's in the same state right now of no medicine on board on how he's able to move. Okay? So we'll watch a little bit more of this. Okay? You can see the left hand now. And look at the tremor in the right arm before how his tremor starts to come out. Okay, this is another lady, older, would be more classic in terms of the age of presentation. And just, I guess I would ask people to think about quality of life issues here. And again, why I'm passionate about doing this, about how this lady gets through life, et cetera. And I want to rapidly just move forward here to what we all sort of take for granted, which is getting our arse out of a chair and walking. You never know how much you're going to miss that until it's taken away from you. Okay? So is this a life and death situation? No, it's not an acute life and death situation. But her ability to actually function, enjoy life, be independent, right? Now, this is a lady who had Parkinson's disease for 10 years. Medication worked very well for her initially, and then stopped really working well, and she was getting side effects from it. This is sort of the struggle I've had over 12 years, is getting people to feel good about having wires in their brain. Nothing good about that feeling, okay? The reason why DBS has grown has nothing to do really with physicians or neurologists. It's by patients going back to their families, to their peer groups, to their support groups, and showing how much better they are. Because if you're sitting around the Thanksgiving table telling your family, yeah, those docs are going to put a vise on my head and they're going to drill a couple holes and stick wires in my brain. They say it really works well. Most people don't think that's a really good idea. So really it has taken patients getting better, us doing a good job and taking care of them to really get out and drive this forward. I've just lost my... I think we'll get it back. I think this actually slipped out, buddy. Okay? So a few of you know who this guy is, and you know what movie this is from, too. Okay? It's another problem. Oops, sorry about that. Let's see if we can get back up to Jack. Jack Nicholson, who looks a little older now than he did back in the day. Okay? From a cultural point of view, we don't like the idea of electricity in the brain. You put a wire in my heart, pacemaker in my chest, great. We don't like the idea of basically using, it's mind control, it's a bad thing, but we're evolving beyond that. So very quickly, these are the things I look for in terms of a good candidate. We don't have to talk too much about this slide. Younger is better, big surprise. But what we've got to be very, very thoughtful about, and I probably see this 1 or 2 years, is a misdiagnosis of Parkinson's disease. I've seen a person go to a wheelchair with cervical myelopathy and treated with Parkinson's medication. Okay? I've also seen a person get a cervical decompression multi-level who really had Parkinson's disease. So there is some overlap in terms of functioning, which is why when we talked about that gait before, really thoroughly vetting this from a neurologic point of view is very, very important. And if I have a question in my own mind, I will trial a person on medication, Parkinson's medication, to see if they really get better. Now, interestingly, if you've got a spastic gait from cervical myelopathy, Parkinson's medication makes you a little bit better. So you really have to be careful. And Martha knows we had a patient in a second opinion who was going to get a 2-level ACDF, who had Parkinson's disease. Okay, a very famous case that we saw together. The other problem is there are diseases that are really bad diseases. One's called multisystem atrophy. One's called corticobasal degeneration. They look a lot like Parkinson's disease at first. But if you do DBS on that patient, they get better and then they get terribly worse. Right? That's why 6 months after the diagnosis, we don't go to surgery. We really want to make sure that these diseases are not evolving into something that's a Parkinson's plus or a Parkinson's like, because they are not people you want to operate on. Is it safe? It's safe. It's not perfect. It's brain surgery. But our profile for both right and left has been very, very good. Okay? You are sticking an electrode in the brain. The brain can bleed. Fortunately, neither of us have had a catastrophic event. And we do many things to make it safe. But from a safety profile, it really is incredibly safe surgery to do. We worry now a little bit that it might be a double-edged sword, meaning any neurologic procedure or any neurosurgery, craniotomy, burr hole that we do on the brain, and any neurosurgeon will tell you this, especially if it's a bilateral procedure, we wonder if we're inflecting some stress onto the brain. So right now we're really looking and saying, we do this surgery and we motorically make them better. They move better. The medicine works better. They're more independent. But are we doing some things long term? Not so much because of the stimulation, because it's reversible, but the stress of the surgery. And it might actually change our timing and the way we screen patients to do surgery. Obviously, I want a patient's quality of life to be at the highest possible place, but I don't want to do anything in the longer term that I think is accelerating additional problems. Parkinson's disease comes along with Parkinson's dementia in patients. So when I screen patients prior to surgery, I want to make sure they don't have dementia at all. I want to make sure the executive functioning is good. But really, this is being scrutinized and looked at very, very carefully. Let's talk a little bit about musculoskeletal problems and spine problems. And Dave Hanscom and I have shared a couple patients, but I also want to do two things with this slide, and that is show you what dyskinesias are. This is a before and after of a patient. And this is real, which is a little hard to believe. This guy lived his life. He was actually a ski patrolman at Crystal, but he lived his life on the left. You'd say, well, why would anyone do that? Why would anyone possibly do that? People who get Parkinson's in early age take a lot of medication because the medication works well and allows them to not be stiff and live a normal life. But they get a secondary effect called dyskinesia, which you're seeing on the left. Okay? Now, the interesting thing about dyskinesia is I've been in the exam room with patients who can't really stay on the couch. They are bouncing off of it, which doesn't surprise you when looking at this. But that's how they live because the alternative is to be off and stiff, not be able to get off the couch. But the musculoskeletal spinal effects of that disease on the left are pretty profound. They accelerate hip, elbow, shoulder, knee, ankle problems. They accelerate cervical, thoracic, lumbar spine problems. So this is where, again, really understanding spinal disease, the timing of how we're going to do this can be very, very important. I'm going to show another interesting case of this in a moment. So I want to just, as I sort of finish this up, I want to talk about sort of what we've done for the last 15 years. It's been about doing this safely, predictably, getting it in the right spot, keeping complications low. And I think without being too dramatic, it can make a big difference in people's lives. But the future is going to look a little different and a little scarier for what I think that neuromodulation and DBS is going to be a part of, okay? So what we've done with DBS is a lot of observation. We put it there and it works, right? We put it there and it doesn't work. We put it there and it causes a side effect. But really, if you're standing in Seattle, you don't really know what's going on in Berlin or Paris or Moscow. Maybe you know what's going on in Portland because you know someone's down the street who got family in Portland. But really what's going to evolve in neuromodulation is treating the brain and the nervous system like a neural network. Okay? Now humans are very much, I want my MTV. We don't care about the whole computer. We want to get diseases cured, which is a good thing. But what we're going to find is instead of just cause and effect, we're going to start to understand how the brain really operates. Most of you know that Ryder's study that he did with epilepsy is contingent stimulation. The electrode in the brain senses a seizure. The pulse generator recognizes it. It sends a charge out to stop the seizure. I mean, that is phenomenal technology compared to where we were 20 years ago. Electrodes are going to start to become reactive, what we call contingent stimulation. That's point 2 here, right? It's not just I press a button, it takes care of the disease. Your brain is one giant neural network. A pulse generator is one tiny network, and it's going to start to interact in real time with that, okay? Part of our problem as a species is we want to cure things. And Parkinson's disease is a very good example of how all the energy, whether it was pharma, whether it was we want to cure it. There's the big win. But the reality is the brain ain't so easy, nor is cancer, nor are a variety of diseases. So the evolution of this is going to be, let's not just race to a cure. Let's understand how this disease begins, the beginning, the middle, and the end. And with the brain, we have powerful technology to do that, but having electrodes in the brain is going to be part of the way that happens. And that's a little scary, no matter what anyone says. But I think electrodes worn on the skull, in the skull, a generation from now, are going to be no different than a cardiac pacemaker, because quality of life is going to be changed so much by it. People probably missed this in November, but there was an interesting article about, which is sort of typical media's, we don't have to drink coffee anymore because we can wear a cap that's just as good and lasts longer, okay? Now, there's some reality here, okay? And the Air Force tested this device on its drone pilots. And they found and I want you to know, this technology costs about $30. It's 2 9-volt batteries, okay? That's about what it costs. And they found reproducibly that drone pilots learned 3 times as fast and had 3 times as much endurance by wearing this for 30 minutes and learning, okay? And they did the comparison to caffeine, which also allows you to learn faster and better, but everyone knows there's a downside to caffeine. There's a lot of upside, but there's downside to caffeine. But this was using about 1 millivolt on both sides for 30 minutes, improve learning and endurance and awareness. Okay? A little frightening. Okay? But I might make one of these. Okay? Right? And I'm sorry, guys. That is transcranial direct current stimulation. Okay? Now, Dr. Melman and his crew use this for depression. There's a wearable device. But the idea is you're basically just stimulating the neural network. But this isn't very precise. It's a region of the brain, but really, you're just generally turning things up a little bit at a very, very low voltage. But it's having some benefit. The interesting thing about reading this article is imagine if you did not have to sleep. Imagine if basically your brain could be trained basically that you really didn't need sleep. Because sleep has nothing to do with the physical body, it has with the rest of the brain. But these sorts of things are going to evolve. It's not a matter of if anymore, it's a matter of when. So here are the tools at our disposal today in 2015. We've got electrodes. We've got incredible neuroimaging that's evolving. We know what diffuse tensor imaging is. What's going to be hugely important is supercomputers that can help us understand our brain, which is still a more powerful supercomputer in terms of the number of calculations it makes, right? All these things are going to come together to really have us understand how these circuits work together. And it's going to happen, I think, much sooner than people can imagine. I think using devices to basically help us understand neurologic disease, the normal brain, are coming very, very quickly, okay? So I'm going to finish with, just leave a little bit of time for questions, with just what sort of motivates me to keep doing this. I enjoy doing it for obvious reasons. This guy I'm going to show you is now about 40 years old. He was a pretty good soccer player in Eastern Washington. He actually was going to get a scholarship to Western Washington, we thought, when he basically developed this weird movement. And went to his regular doctor, didn't know what it is. And he spent 10 years of his life with people telling him he was crazy, drug addicted. And when I show you this, you're going to see why probably when people saw him, they really thought there was something that was incurable. Now, normal intelligence, by the way, if not to a little higher intelligence, okay? And this is a disease called idiopathic dystonia, okay? That's Peggy Short's voice in the background, okay? Sorry, hold on. I just want to show you what his walking looked like. See if we can get Brendan back up here. Okay, so he's got severe dystonia, which is not Parkinson's disease. but it's severe cramping of the muscles which can't be controlled. And the longer it goes on, the more severe it becomes. Okay? You can actually have changes in the size and shape of the muscles, size and shape of the spine. Okay? And this guy, up until about this point, was living alone. Okay? Now, obviously, I think also say, gee, in the prime of your life, this is kind of a tragedy for people to not knowing what this was, right? And also telling you you're crazy. Okay? So he was kind of angry when he came to see us, and I guess I don't blame him for that. And he found us, we didn't find him. Okay? Now, I mentioned before the musculoskeletal and spinal problems. Think about the musculoskeletal and spinal problems in this guy and how they might have been obviated had we gotten to the answer sooner. Okay? Now, I'll just finish up showing you this, which he actually sent us. Okay, so this is his night before the surgery at the inn. He sent me this with this sort of cool, I don't know, newspaper thing. I know it's hard to see, but he's shooting this picture, getting ready for surgery for his own remembering of what happened, what was going to go on, right? So you can see it's good to have his shirt off because you'll see his muscles in back, how much camptocormia he has, which is this pulling of the muscles, pulling you over. And truly, he walked forward with his head back. This is how he sort of got by when he wasn't in his chair. Okay? Now, the problem why this guy is sort of, this is an important video that I watch a lot, is we got to this guy too late because of ignorance of the medical field, us not really understanding what dystonia was until relatively recently. Okay? So you're going to see the next piece of this video is going to be something he sent us 2 years out. Okay? What you can still see is you can still see some of that dystonia. But he sent this to us, I think, primarily to say, there's my life before with my electrized wheelchair, which he was going to sell. So he had to dig it out of the snow. Okay? Right? But not perfect. You can still see the tightness in those muscles of the neck. And cervical dystonia is one of the hardest things to get rid of. But really a game changer for this guy who's now 40 years old. Okay? And the nice thing is the durability of that response should be very, very good for him. Right? My worry is obviously what about his cervical spine, thoracic spine, et cetera. But to date, he has had no really major problem. This is a much better place for him to be. Okay? So Dave, to your question, to what I said before, we are squeezing that, trying to squeeze that envelope as much as possible. There's reasons I alluded to in the first year of diagnosis, you've got to be very careful. We placed DBS in a woman 3 years ago. She sort of pushed the envelope. We sort of pushed the envelope. She had something called multisystem atrophy. She did well and then plummeted very, very quickly. So if you've got some of these other very serious degenerative diseases, you really, and they don't necessarily rear their head, they can look very much like Parkinson's disease, it's a terrible situation anyway, but it'll be very difficult for the family to deal with. It's not Parkinson's disease, not something else that's significantly worse. You're 3 years into it. Yeah. Sort of mild symptoms, not horrible. Right. Why not? You're preaching to the choir. We'd say absolutely, but again, you are still overcoming this idea of using electrodes in the brain, right? I mean, one of my patients the other day was playing soccer with his kids. I say, please don't hit the soccer ball too hard with your head. It really is getting over this emotional idea of, this is now part of my life, and my quality of life is so different. But that is a leap for many, many people.
And are people coming off medications?
Most people reduce their medications by about 50%. In the case of that guy with dyskinesia, the ski instructor, you can see how critical that was to his life. Most Parkinson's patients still require a small amount of medication for the best possible result. Yes, sir.
Dr. Nora, I actually had the line fighter jets in years the original helmets that came out were just standard helmets. That's okay, sir. That would do nothing. As technology increased and the ability to assimilate information became more difficult with a HUD in your helmet, they actually experimented with exactly what I just saw back in 2008 and 2009. And among the senior pilots, night and day. I remember feeling energized, ability to assimilate information. It literally felt like the uppers that you would give us right before an 8-hour, 9-hour
Right.
combat mission.
Right.
And we begun to fight over who got, 2 or 3 helmets that we were assimilating. I'm not getting any squadron.
No.
And that was directly a result of the newer technology coming out, aircraft. Just, it's so hard for one pilot to assimilate it all alone. And what you just showed is an exact example of the experience in an absolute trustworthy.
Right. No.
It's literally like taking 3 or 4 caffeine pills.
And now thank you for providing. And now they've actually shown that really in a blinded way, it really is making a difference in learned tasks. And not the same side effect. The problem with caffeine obviously is there's a fall off and a drop off very rapidly. Yes, sir.
Earlier I was seeing patients guys with TDCS with a lot of surgical restrictions, don't go.
You know, actually it's much more infrequent now because literally the type of silastic that's used from the company, from Medtronic who makes them, has changed to be much more flexible. Okay, and I would say that's rarely a problem now. I think it's the way you advise and educate your patients afterwards. A lot of times they want to keep their neck very still. You don't want them to keep it still. You want them actually to move their neck.
I also want to reiterate this patient with the movement disorder before that. I did share a patient with Dr. Nora. Oh God, about a year ago I saw her, and it was just as bad. I mean, worming movements in the wheelchair. I couldn't talk to her. We couldn't hardly look at her. It was horrible. And she had some spine issue, big pinched nerve at L3-4, needed a fusion. So the change in her demeanor was as dramatic as you can imagine. I just saw her last week, by the way, and she's fine. It's unbelievable.
She's better. Okay, we want people to be.
I mean, the bad news is now she's complaining of back pain.
Right. You bet. Thank you, everybody.
Fantastic talk. Yeah.